Look, thank you very much for that very generous welcome. And look, I do apologise for not having been able to be at the meeting because I have had some prior commitments. And look, it is an honour and a privilege to be able to present today. I'm going to give sort of fairly direct and sort of fearless commentary. So this is not directed at anybody personally, but I think I'm just going to try and sort of raise some of the challenges that I think we need to consider. One of the critical issues for me is that it's very easy to think of a researcher as a person who lives in an ivory tower. And I thought what I might do, just to begin, is to point out that as a psychiatrist, there are many different roles. I mean, the first one is as an individual and a person. I've had two close friends, one who was a fellow professor of psychiatry, commit suicide. I'm working as a doctor. I have assisted in an operation of a man who died on the operating table, having shot himself through the liver. So look, these are not matters that I see at a distance. And obviously, as a clinician, I've worked with many people who have been struggling with their despair. And one of the other real challenges as a psychiatrist is actually having to administer the Mental Health Act and at times remove people's freedoms. And that is a very challenging and difficult issue and does require one to think about what evidence and information there is. But I'd also like to say that obviously I've been a director of a mental health service, and the challenge is that if you bring the problems of the system to people's attention, they don't always welcome it. I once wrote a letter to the chairman of the Health Commission about the unnecessary restraint of patients in the emergency department of the hospital where my position was, and the result of that was to have an inquiry which removed the funding for my position, although there was no criticism of my role. So, you know, look, these are not neutral issues. And so I thought I should just provide some sort of evidence of that background. So please don't think of me as somebody who sits in an ivory tower just doing research. You know, I've made submissions to all the major inquiries that there have been into suicide to try and bring these issues to attention. And I think it really brings us this whole question about, and I very much appreciate the Commissioner's invitation to speak at this meeting. And, you know, really what would we hope were the outcomes from this Suicide Commission? And I would suggest that they are to stop the preventable loss of life, to identify the failings of the system and implement steps taken to correct those failings. There is this critical issue of ongoing accountability and responsiveness to identified failings, and I will talk something about that. I think another really important issue is to apologise and accept responsibility by those who've erred. And I think, you know, it's an interesting state of public bureaucracy these days that after the Ruby Princess entry into Sydney Harbour and the bungled hotel quarantine in Melbourne over the COVID-19 issue, what's fascinating is the lack of responsibility. When you have an aircraft accident, air traffic controllers and potential people with responsibility are stood down until the errors have been identified. I think we need those sort of reassurances in the health system. And obviously my hope is that the system will change for the better. So what are the touch points here? I think the critical question is, you know, what are the domains of care that can make the most difference? You know, when a person does suicide, who is responsible? Were there clinicians who failed in their duty of care, or is there something about the system of care? And I think in the space of veteran suicide, there is this whole issue about organisational responsibility between the ADF and DVA. And behind all this, I think, sits this critical question about what opportunities have been neglected and knowledge not used, and really have the systems adapted to the known information. So what I'd like to do is just to focus on just a couple of key principles that might inform intervention, you know, and really what does knowledge inform? And what I've done is just to randomly pick 3 papers, 2 of which have been published in the last 2 weeks, and a further one which tried to aggregate knowledge that had been used in the development of suicide risk scales. And this is this first paper. Now, one of the things that often happens in hospitals, most teaching hospitals, is that a risk assessment scale is completed by clinicians. And this publication, published in 2017, really reviewed those and their value. And one of the key issues here is the challenge of prediction of these measures, because suicide is an infrequent event and its prediction is subject to the limitations found in the prediction of any infrequent behaviour or event. In other words, there might be risk factors, but those risk factors might be so common that they should make very little sense because they have a very poor capacity to actually predict the person who is at risk and identifying them correctly. And now, this paper basically concluded that when reviewing that evidence, the National Institute of Healthcare and Excellence in the UK said, don't use these measures. Now, a lot of effort is put into trying to identify the risk factors for suicide, but essentially what it's saying is that these risk factors are so prevalent that they lack any real use when you've got somebody sitting in front of you about the risk of future suicide or harm. Now, that doesn't mean there aren't predictors that we need to manage in clinical settings, but these scales that have been developed actually have very little utility. And what they've really argued is that what you need to do is, rather than assessing risk, it's about the needs assessment. So it's what does this person present to you where you can intervene. You know, as a psychiatrist, this is really about treating psychiatric illness properly and dealing with people's psychosocial circumstance. And essentially, what they concluded, that you've got to provide evidence-based care, you've got to apply relationship counselling and psychosocial support, and it's about following people up. So the critical question is this: what the systems that are in place in Australia do. Now, another really important recommendation from a similar paper highlighted the importance of aggregating these things. So if I could just sort of finish up with summarising that paper, saying that what the first principle is to provide optimal care because risk factor measures have poor utility. And this leads to the question, is the system providing optimal assessment and care of ADL personnel and veterans? So, as I said, another paper looking at those scales said that what we also need to do is use this modern technology of machine learning to look at large data sets. Now, what machine learning does is it doesn't start off with a hypothesis. It basically aggregates large amount of data and then tries to look at, well, if you use data without any preferential hypothesis, what are the things that predict risk? Now, this study was an American population that had two waves that were essentially 3 years apart and was based on face-to-face assessments. These are very large populations of 34,000 people. What it found was that there were 222 people who had attempted suicide in the intervening periods. And it identified that there was this small population of people who accounted for the majority of the suicide risk in that population. Now, what were the things that this machine learning approach identified as telling us who these people were? And this really tells us about where we should direct our attention in clinical practice, so that the people who've had previous suicidal ideation or behaviour, and then on a very sort of brief health questionnaire, they were basically feelings of being downhearted, i.e. depressed. There were people who were behaving with a degree of lack of care for themselves, and there were people where their emotional disorder had led to significant loss of activity. Now, obviously, there were psychosocial issues, younger age, lower educational achievement, etc. But you can see as a clinician, you can't treat everybody who's young, got low educational achievement in a financial crisis as being a suicide risk. Really, where the money sits is in the original, the first two areas. Not to say that these other ones are irrelevant, but as a clinician, you can't, basically provide care on the basis of very, very general socio-demographic characteristics. So the second principle then is to focus on clinical assessment and include prior suicidality, mood assessment, and psychosocial disadvantage. Now, the big question then is, does the system, or do the systems provide that assessment and intervention? Now, the third one, the study that came out recently, was a longitudinal study of veterans. Now, did this add anything further? Now, essentially, this was a follow-up of over 2,000 veterans over 7 years who were assessed on 4 occasions. And it found that, basically around 1 in 5 had some form of suicidal ideation. And the interesting issue was when you compared the group who had no suicidal ideation with the chronic suicidal ideation group, there were a number of important issues. The first one was childhood trauma. The second one was major depression or post-traumatic stress disorder. physical health difficulties, and recent traumatic stressors. So what that's saying, as a clinician, if you're really worried about somebody, how do you work out which are the ones who are going to have chronic suicidal ideation? And it's identifying these issues. Trauma is essentially a critical issue, physical health, but critically depression and post-traumatic stress disorder. Now, the things that we can change are depression, post-traumatic stress disorder, and ensure that people are getting good physical health care. So the third principle here is that in veterans populations, childhood trauma and adult histories are further important variables in clinical settings, and are current clinical systems adequate to the task? So really what I'd like to just review is what research we've done that does it confirm these sorts of general principles, and equally, are the systems adequate? And I think the really important issue is that we have had an enormous amount of inquiry into these issues. In the last 3 years, there have been three inquiries specifically into veterans, and there are two more general ones. And I'd just like to refer to these because I think the real challenge for us is, why haven't there been changes already? Now, the Productivity Commission, I think, was a very important document, because basically it said that the veteran system requires fundamental reform. Now, the question is, has that occurred? Now, it's not for me to answer it, but I think we know that the system requires fundamental reform. That has been told to us. The second thing is, I'm just summarising several very brief points of this huge report. It talked about the difficulty of navigating the inequitable nature of the system and it being poorly administrated. Now, have these issues been addressed? I think these are critical questions. If we're going to prevent veteran suicide, it's about how these matters are being considered and responded to. And the third issue, and this is the one I think is of particular importance, is about the way that treatments and supports are commissioned and provided to veterans and their families, because this requires change. And it particularly needs to be responsive to the use of data and a greater focus on outcomes. And as I've highlighted, there are some very key principles that we can derive from the immense literature without us having any further inquiries. Let's just use what knowledge we have. I mean, often academics are criticised for not translating their research findings into recommendations. Here we have the Productivity Commission saying that the system needs to do that. Finally, it said that more can be done to respond to new research findings. So the research findings are there, but what is happening in response to those? And there needs to be developed targeted and implemented suicide prevention programs. Has that happened? Has that occurred? Here we have the Productivity Commission making it very clear what needs to happen. Now, the next major inquiry was by the Joint Standing Committee of the House of Representatives of the Senate into Defence, Foreign Affairs and Trade. And again, it makes very similar recommendations. There needs to be developed and implemented specific suicide prevention programs targeted at those veterans identified in at-risk groups. I've already shown you a body of data that shows we've got very good information about who are those at risk, but I will now, point to what we know from the ADF. And the second thing they highlighted was that the Productivity Commission's findings needed to be implemented, particularly in the areas, for example, of service delivery. Has that happened? That's the question. If it hasn't happened, why hasn't it happened? Now, the next issue I'd like to focus on here is that they highlighted also the service provision gaps and the need for a step care program. Now, this actually comes from the third inquiry, which was the National Mental Health Commission's inquiry into suicide prevention in veterans. And this really highlighted, I think, very importantly, this whole issue about a step care framework. Now, is there a step care framework available for veterans? Is it adequate to the task? And often we've got to remember that it is utilising other health services. And this inquiry also highlighted the way that the system was viewed by the veterans, there were many negative views. And so that the issue is that, the perception of these systems is a negative one. So there are two other inquiries I think that we need to think about in terms of the context of veteran services. And really the issue is, how much evidence do we need to drive change? Because one of the important issues is that, whilst people are in the ADF, obviously the ADF has its own health system, but it still does depend on the broader health system. If a soldier is suicidal, they will often get taken to the local mental health service and turned away because they're not at the level of acuity that service will respond to. Equally, once you leave the services, we know that even if people have DVA entitlements, only about 40% of people actually use DVA-funded services. So the importance of these inquiries, first of all, the Productivity Commission's general inquiry into mental health, now this is not specifically about veterans, did this comprehensive review and basically summarised that the system is currently not comprehensive and fails to provide treatment and support that people who need it legitimately expect. And it doesn't provide prevention and early intervention. So this really is saying that, that if we are really concerned about veterans, we cannot assume that adequate care is in there in the community, that a special system needs to be put in place. And, I think what's happened was the closure of the repat hospitals. There's been this assumption by DVA that adequate services are in the community and can be purchased. I mean, I've actually had the secretary of the department say that to me in front of the minister when I was suggesting that such services, particularly in the trauma field, don't exist. Now, the next major inquiry that's just been released, which was the Royal Commission into Victoria's mental health system, and I would suggest that if you did a Royal Commission into the health systems of any state in Australia, you would come to exactly the same conclusions. And essentially, that the mental health systems in Australia have deteriorated. So they haven't even got better. They've actually got worse for multiple reasons. And this has been going on for a long period of time. I mean, there's not a lot here that leads to optimism. The important issue that often services are inaccessible, particularly when they would make the most difference, and they're complex and fragmented. So, and one of the challenges often for veterans is that they leave the ADF and have very little idea about how to negotiate the health systems. And this is saying that the system is rather impregnable at the best of times. What's gone wrong in our mental health system? Demand has overtaken capacity, community-based services are under supply. I think this all makes sense. So that they can't keep up with the number of people who are requiring treatment and care. The missing is middle, and often this is where veterans sit. They're too complex for GPs, but they're not severe enough to enter the specialist mental health system, and we know that happens. And we also know that suicide is a critical issue and has many broad determinants, and the Commission called that they be addressed. Now, and I think there were several particular recommendations that Commission made that I think have particular relevance to our conversations, that there should be a straight-white trauma centre. We know that trauma-informed care is very poorly and inadequately provided across Australia. DVA assumes that it's there and can be purchased. Here we have a Royal Commission saying that's not the case. And there needs to be a specific focus on suicide prevention. So so the question is, why don't we use what we know and create a system that has accountability? And what can we do? I mean, I think these are critical issues. And I'd just like to tell a story about the Vietnam veterans and why there's a salutary reminder in this. When the Vietnam veterans came back, there was a belief at the time that the systems in place were so effective that there weren't going to be psychiatric casualties. This is written by a very influential American psychiatrist. But what happened was that a generation came back from war who had suffered grievously, were ignored and stigmatised by the system. And interestingly, they joined with the women's movement who'd been subject to domestic violence and rape. But there were two American senators who particularly took on the veteran system, both who were World War II veterans. And what they were deeply troubled by in repeated inquests was the failure of the veteran system to respond despite the evidence and the advocacy of veterans. And one of the ways they dealt with that was to call for the Vietnam Veterans Adjustment Study. And and one condition of that was that it could not be done by anybody who had any relationship with the government or the veteran system. And this was a key piece of research because it identified that for once and for all, the PTSD wasn't some fictitious idea. This is the reanalysis of the data in 2006 that was published in Science. And the other thing that those two senators did was to create a body of independent clinicians and academics who oversighted and critiqued the veteran system and provided an annual report with recommendations for intervention that went to the Undersecretary of the department and then were given to Congress. So the department could not stop the independent scrutiny. And I think that's one of the reasons why there has to be independence of research of the veteran system. Now, I was involved with a number of people who I suspect are here in doing the mental health prevalence study. And I think this is a highly commendable piece of research. And the work of people like Steph Hodson and others to get this going in the Defence Force and David Morton, I think, was tremendous. And this was on the back end of the Dunt Review, which I think was, again, a very important development in Australian military mental health. And essentially what we did was to use a methodology that allowed comparison with the Australian population. And we found that there were very similar rates of mental disorder in the ADF and the general population, but a higher rate of affective disorders and a lower rate of alcohol abuse. Now, you might say, how come lower rates of alcohol abuse? One of my friends always says to me, remember the drinking habits of university students. If you put young people together, you get a lot of alcohol abuse, and the ADF has done a good job, I think, in that space. But what was alarming in this study was that the rates of suicidality in the ADF were significantly greater, about 4 times greater than the general population. And there were 1% of ADF members were making suicidal plans, and this was more common in the female members of the Defence Force. But there were no differences between suicidal plans and attempts between the sexes. So, this is a very important issue. Now, what we were able to show was that there was a strong association between mental disorder and suicidality. I'll come back to that. But the interesting thing here is that we don't want to assume that everybody with a mental disorder has attempted suicide or has suicidal ideation. It was only 2.8% of those with mental disorders. And this is this whole issue about prediction. But the really important issue is that 0.1% with no disorder had attempted suicide. And I'll come back to those figures because it shows that if you really want to make a difference, you've got to focus on the people with a mental disorder. And the mental disorder that was particularly important in the ADF was depression, the affective disorders and bipolar disorder. There were no differences between the services. And an intriguing finding, and I'll speak to this in more detail, was that those who deployed were less likely to report suicidal ideation, which was not what we were expecting. Now, the reason for that was because the people who were deployed were actually a psychologically healthier group and had less lifetime trauma from other reasons than the people who were deployed. So the fittest of the fittest are deployed. Now, I think the ADF had an extraordinary intervention, which was remarkable and needs to be acknowledged, that everybody who we contacted as part of that study had a clinical assessment if they had suicidal ideation and were provided with an intervention. And this was to ensure they were adequately connected to health services. So the ADF really accepted its duty of care. This was seen as an opportunity to have screened the ADF population. And what the ADF then did, the Joint Health Command, was to commission further analyses into, well, what were the determinants? Could we get any further information? And one of the things that we looked at was, well, what were the traumas that people in the ADF were exposed to, and which ones are of particular importance to suicide? And these were essentially rape, being threatened with a weapon, captured, kidnapped, being tortured, domestic violence, witnessing suicide, child abuse, both of emotional and physical type. So this tells us that trauma is a very important add-on to psychiatric disorder, similar to what that American study showed. So we're actually confirming and have confirmed what the US have highlighted. And what this table shows is that we looked at people who had a psychiatric disorder with environmental traumas, 3 or more, or a psychiatric disorder with interpersonal trauma, 3 or more. And you can see that those with interpersonal trauma are the ones who are particularly at risk, like that previous table. So if you've got a psychiatric disorder and interpersonal trauma, you've got 15 times the risk of a suicide attempt. So, if you really want to, as Al Capone once said, when asked why you rob banks, he said that's where the money is. So if we really want to do something about suicide risk, we look at the people who've got histories of trauma, particularly interpersonal trauma, and a psychiatric disorder. Now, interpersonal trauma itself increases the risk, but not nearly as much as if somebody has a psychiatric disorder. Now, this table is a slightly convex one, but it highlights that the affective disorders are the highest group for suicide attempts. But what I want to focus on are these 2 numbers here. You can see that in the ADF, in the past year, there were 303 people. There were 337 people who had attempted suicide in the previous year. Now, of those, 303 had some form of psychiatric disorder, and 34 had no disorder. And this tells you why psychiatric disorders are such an important issue to think about. These are things that can be treated. Now, it's not to ignore the other group, but you can see that if we have got limited resources and we have systems of contact, this is one place where there is a potentially very high yield. So the question is, are those systems working well? And it would seem from what the Productivity Commission, the Senate inquiry said, from what the Royal Commissions are saying, is that we're not doing a very good job. Now, what are the psychiatric disorders in the ADF that we found were important? They were depression, bipolar disorder, panic disorder, GAD. And if you had more than one disorder, which is common, that significantly increased your risk. And it was this whole issue about interpersonal trauma. So the point is, what we're finding here is exactly what we find elsewhere. We've identified these issues in the ADF. What do we need to do about it? Have we got the systems to address these issues? Now, a colleague, Rebecca Syed Sharif, did her PhD on this, and she looked at a further issue, which was about the childhood determinants. Now, this is a complicated one because I think in the veterans population, it's very easy to focus on the importance of military-related trauma, and I think that's critical. But and this can be a difficult one to talk about. But what she was able to show was that childhood trauma is an important issue in ADF personnel, and that children or people who go in the ADF are more likely than the Australian community to have had childhood trauma. And this is a significant predictor of suicidality in ADF people. Now, what does that mean? What that means is that I believe that what we should be doing is that often these people's difficulties become manifest relatively early in their military careers, that we should have a system that provides particular interventions and care for them. The Singaporean Defence Force, which is a national service defence force, employs 5 child psychiatrists, really because they recognise that some of these issues become manifest early in military careers. So what she found was that childhood anxiety in particular has a strong and independent relationship with suicidality in the ADF. So if somebody's had some childhood anxiety disorder, this is a group where we could potentially reduce something early in their career. And childhood trauma exerted its effect through those anxiety disorders. So this is something I think where we need to think that there is a group who come into the Defence Force with this risk factor, and we need to do something about it. Well, following on from the mental health prevalence study and the MEO census and prospective studies, the ADF transition research project was done, and Miranda van Hoof was the lead researcher and did a wonderful job on this project. And essentially, one of the things that this gets to is if you want to understand the health of the military population, you don't just look at currently serving, because those people who are not doing well leave. So we actually need to look at the combined population. And essentially what we did was to follow up all of the people who transitioned between 2010 and 2014. We went back to all of those who had responded to the 2010 study in the ADF and also to the MEO prospective cohort. Now, as you can see here, the rate in the ADF was 22%. In 2010, the rate of psychiatric disorder in ex-serving populations was 46%. Now, that was far higher than we anticipated and a matter of considerable concern, given all the efforts that are put in to improve the care of those people. But it tells you that the interventions that are being provided are not optimal. We need to do more. And this basically summarises where the prevalence of those disorders lay. It highlights the importance of affective disorders and anxiety disorders, and the importance of comorbidity. 17% in the previous 12 months had post-traumatic stress disorder. Now, even more alarming was that 21% of those who had discharged had experienced suicidal ideation. And we calculated that there were 1,965 people who had had a suicide plan. That was an estimate, and there were 505 people who had attempted suicide in the last year. And this was greatest 3 years post-transition. And this was not expected, and it was highlighted in the presentation of the findings. Now, what was DVA's response? First of all, when we wrote these reports, in contrast to the defence report, we were specifically requested not to make recommendations. Now, I would see that the people who know the data and know the system should make recommendations, even though the bureaucracies don't like that. Secondly, that there has been no systematic policy response in conjunction to clinical advice to these findings. And I know that because of my roles. The DVA, despite our attempts, unlike defence, did not recontact people who had suicidal ideation, even plans, despite having essentially screened this population. And I believe there was a duty of care. There were no further analyses conducted, as was done with the defence process, with the defence research we did. And the other thing is that the deployment health surveillance program that essentially was looking at, and I've been involved in all of these going back to 1998, except the children of the Vietnam veterans. That program has essentially been disbanded. Now, DVA might argue that the Australian Institute of Health and Welfare are running that program, but that is not the same research team. That is not people who've got content expertise. And you can see, I believe there is a duty to follow these people because of the trends that are being shown and to find out whether the system is responding and ameliorating these risks. So it's not that we don't have the data. The issue is, do we act on it in an impartial way and exercise our duty of care to the veterans community? Now, the other issue with this is, it gets back to this whole issue, is with infrequent phenomena, we need to focus on case studies. Now, one of the problems with research such as the research done by the Australian Institute of Health and Welfare into completed suicides is that in Australia, we don't have sufficient numbers to actually do properly statistically controlled studies. In America, they have the sufficient size in their population. And this is one of the reasons why I would argue that we have to have inquiries that look at specific case studies. And I've been involved in a number of these inquiries, because what they essentially do is dissect where the failings in the systems occur. And I don't think that the sort of research that I've been talking about today either collects that data or can really inform us about where those failings in the system occur. So if I go back to where I started, so one key principle is to provide optimal care because risk factor assessment have poor utility. And I put the question, is the system providing optimal assessment and care to ADF personnel and veterans? Well, the issue is that the various inquiries, and this is not me who's saying this, are saying, no, it's not. What do we need to do about it? Principle 2, we need to focus on clinical assessment, including prior suicidality, mood assessment, and psychosocial disadvantage. The research in the ADF and the veterans community absolutely highlights these issues. Do the systems provide this assessment intervention? Well, we really don't know. And I would suggest they don't. I mean, there have been some very good studies done which show that if you have a targeted intervention for somebody who presents to a hospital having attempted suicide or with a high level of suicidality, it significantly improves the outcome in the following 12 months. And I can tell you that the emergency departments of our teaching hospitals in Australia do not provide that sort of follow-up. The point is, We have to do something different with veterans. It's not being provided to the general population, which I believe is a problem in its own right. But with veterans, Veterans Affairs has an unlimited treatment cap. Why haven't those sort of programs been put in place? What we also looked at in the Defence Force and was what was highlighted by Principle 3, in veterans populations, childhood and adult trauma histories are further important variables to assess in clinical settings. In general settings, they get completely ignored in most psychiatric services. People's trauma histories aren't adequately assessed. And, one of the reasons why the Victorian Royal Commission has said a trauma-informed service needs to be put in place is because the current systems aren't adequate to the task. So I think the principles require optimal trauma-informed care are a critical issue, because this is what DVA assumes it can purchase, but I think are not there in the community. And it's critical to suicide because this is an important risk factor. Optimal care, depends on appropriate treatment for the population you're dealing with. And what we need to make sure is that the systems that are being provided to veterans, if they present with suicidality, are properly assessing prior suicidality. There is proper assessment of whether people do have psychiatric disorders that can be treated, as well as having a system that deals with their psychosocial disadvantage, if that is a major issue contributing to their current mental state. It is about getting this lifetime history trauma approach. So going back to the beginning, you see, I think there are opportunities to stop the preventable loss of life. We have an enormous amount of information about identifying the failings in the system, but have we implemented the steps to correct this? And I think this is one of the critical issues for the Commission to address. And I think the main issue here, which I find constantly perplexing, is about the lack of accountability and responsiveness to the identified failings. I think the real challenge is, what can we do to make the system change for the better? There's been an enormous effort, and I think collective pressure behind having this commission presented, and let us hope that it can meet this change. And I think this really goes back to this question that I said, which are the key touch points. So I think we really do need to go through these questions and ask, what are the core domains where we can make the most difference? When a person suicides, and I think we should look at individual cases, who is responsible? Is it the clinician? Is it the system? And one of the challenges is that it's extremely difficult clinicians who are working in under-resourced systems, because it means they sometimes have to live with risks that are extremely burdensome. There is a cost to clinicians who have patients who suicide. Now, I'm very lucky to have not had a patient I've looked after in my clinical career commit suicide. I've had a woman who jumped under a train and survived, which was extremely difficult. But this is something that can be very burdensome, I think, for those who take on the responsibility of trying to assist. And, I think the ADF and the DVA are in a unique position to oversight this. And there is a collective will, I think, amongst the public and the politicians to do something about this. I think the ADF has done a lot over the last 20 years to improve things. What we need to really identify, what are the opportunities that have been neglected and where knowledge hasn't been used. But the other critical issue is, how have the systems the capacity to use known information? How do these systems aggregate information? I mean, I just chose 3 random articles that very simply defined 3 key principles. Where in our systems is that information aggregated, advocated, and presented to bring about change? So, just at the end of it, I highlighted I've had a whole range of roles. So which would I say has been the most informative and effective in preventing suicide? Because there are a whole series of different types of knowledge and different usages here. And I would actually say being involved in boards of inquiry, where systems are held to account and critiqued, have been of particular importance. And I think the legal process is an invaluable one in that domain. And I'd just like to end with this one thought and one reflection of the Productivity Commission, where it said more can be done to respond to new research findings. So this is not just about researchers living in their ivory towers. It's about how systems engage with researchers and listen to the findings and actively explore their meaning and use that information to try and prevent the terrible tragedy of the loss of life of people, particularly those who had served the nation. I'll stop there.